Dhruvi Hasnani and Dr. Vaibhav Dungre. Yeah. Thanks a lot, sir.
Thank you, sir. Thank you. Thank you. I take both the mics there. Hi, good evening. Good evening. Nice to meet you. So we've had a very, very fantastic session on the basics of diabetes, and all of us are almost, up after a little, let's not call it a slumber. So now we have a very dynamic technology session, diabetes and technology, and we have even more dynamic lectures coming up with very vibrant speakers. So now I'll request Dr. Vaibhav Dukle sir to introduce our very first speaker.
The first speaker is Dr. Maluk Mohammed. He's going to speak on the reversal of diabetes using whole body twin technology. He's a doctor. He has a doctorate degree from IIT Madras. He has guided around 13 PhD research scholars with multiple patents on health technology. He heads the India operations for the company, and prior to founding Twin Health, he played an important role in transforming the higher education space in Tamil Nadu. With this brief introduction, we'll have Doctor speak on this.
If we have Vinay sirs ready and if you permit, can we move ahead with Vinay sirs and then in the meantime resolve this? Yeah, that sounds comfortable. Dr. Vinay Dhandania, sir. So, Dr. Vinay Dhandania is a consultant diabetes and metabolic physician. He is an honorary diabetologist for Seva Sadan and Orchid Medical Center for Ranchi. He has been the principal investigator for ICMR, MDRF, NDIAP study. He's been faculty to numerous national conferences, seminars, and workshops. He is a very, very known and prestigious faculty, academician, and scientist. He has been the secretary RSSDI Jharkhand State Chapter and is an alumni ISB Hyderabad. So, Vinay sir, over to you.
Thank you, Dr. Dhruvi, for that very kind introduction. And at the onset, I thank the whole team of Diabetes India for this opportunity. This is going to be a workshop on point-of-care testing in diabetes. And I tell you, we are doing a lot of point-of-care testing, not only in diabetes, but each and every field of medicine, from doing an optimal test for malaria, for TROP-T in emergencies, for NT-pro, BNP. So all these things are very, very popular. So similarly in diabetes, I'm going to talk about a very relevant point-of-care testings. This is the definition by College of American Pathologists, which defines POCT as test designed to be used at or near the site where the patient is located that do not require permanent dedicated space and that are performed outside the physical facilities of the clinical laboratories. I tell you, we can carry the devices from one clinic to another and do the point-of-care testing. This is the advantage of this particular process. The US FDA even similarly defines POCT A1C as a device used to measure the percentage concentration of HbA1c in blood, and the measurement of HbA1c is used as an aid in the diagnosis of diabetes and as an aid in the identification of patients at risk for developing diabetes. So we have a lot of even automated POCT devices which are available. We even have a recommendation from our own country. This is a very published data in 2019, which actually gives the recommendation for in-clinic POCTs for diabetes management in India. I have a couple of scenarios which we see in clinical practice. It's a very, very common scenario. We get patients referred for fitness of surgeries. This was before a cataract surgery. And the patient had done a lab test 2 days back. And he went to the ophthalmologist and said, I have come with the report. Just I need my cataract surgery to be done. But the colleague of mine actually refers me for any cataract surgery in a diabetic for fitness. So he was like, just give me a fitness, I have the report done 2 days back and nothing else. But in our clinic, we have a routine that we do a blood sugar random in our clinic before giving them a fitness. The moment blood sugar was done, it was 436. And you know what the patient commented? He said, sir, ये डिबिया आपका खराब है, हमारा शुगर 2 दिन पहले किया एकदम बराबर है. Then we did a HbA1c, it was 13.5%. And then we again repeated his urine for ketones and sugars. He was urine sugar 3 plus and ketones absent. Then I told him, you want to get operated, you get it operated. We are not going to give you fitness. So we have multiple reports which can be correlated at one time to suggest that this patient was actually keeping a uncontrolled diabetes, and cataract surgery is not permissible. It's not safe for him. So this could be done in 10 minutes time. Can you believe this? So this is the advantage of POCT. Similarly, we had a 9 weeks pregnant lady, 32-year-old, was referred by a gynae colleague for management of her blood sugar. Now she was detected diabetic for the first time. She had a fasting of 180 and a PP of 270. Now she was in denial and not ready to accept her report. मेरे को आज तक कुछ प्रॉब्लम ही नहीं है, कुछ सिम्टम ही नहीं है, मुझे शुगर कैसा हो सकता है? Then she said, मैं तो दूर से आई हूँ, मैं तो जाऊँगी तो मैं कल फिर से नहीं आ सकती हूँ. And we did a blood sugar, HbA1c and urine. In 10 minutes time we had a report. Blood sugar was 225, HbA1c was 9%, urine sugar was 1 plus and ketones were absent. She was diagnosed as a pre-existing type 2 diabetes. You know, the whole prognosis of this particular case changes the moment you do a HbA1c with a normal HbA1c and with a higher HbA1c. You can actually prognosticate this lady that you are very likely to have a congenital anomaly. So these are the real world advantages of doing a POCT in your clinic. And believe me, they are very, very simple today. So this is how it actually flows on. Patients, you can actually, you see, patient arrives for appointment, finger prick sample has been given, and they are readily available. I mean, the results are ready in minutes, 7 minutes, 10 minutes. These are the minutes how you get your reports. Like you get a TROPI report in your emergency, ABG reports in your emergency. They are all what? ABG, this is nothing but a POCT. You have a small gadget in your hand, you take a arterial blood, and put it there in the cartridges, you get the report. Along with electrolytes you get a hematocrit. So a lot of data you get today by POCT devices. So why they are becoming popular? Because of the compactness, fast and accurate, immediate decisions you can make, improve patient care, non-laboratory personals, you don't need a trained setup for it, and portability, as I said, from one clinic to another you can carry them. Testing compliance is poor in diabetic patients. This is also very, very important to understand that I heard a couple of lectures since morning. Patient एक बार आता है, फिर साल भर के बाद या 2 साल के बाद दोबारा आता है when they have some problems, not for follow-up. So you can understand how the compliance is for testing. So Indian health cost to treat diabetes reached over 73K crores in 2017. So this must have multiplied by now. So poor testing compliance leads to increases prevalence of complications in type 2 diabetes. And with the compliance with guidelines, the target is also poor. Only 26.7% of the patients diagnosed with diabetes meet the targets of glycemic blood pressure or cholesterol control. I've heard this in last 3 or 4 lectures, one by Dr. Bansi Sabu in the morning, later by Dr. Parikh in the other hall. So everyone is actually trying to quote upon that. But the important thing is the data which we are talking about today. How many of us are actually doing HbA1c for our patients? You know, the data is only 2 to 4% of the people are having POCTs in their clinic. Can you believe this is the data today? So we need almost 70 to 80% of the patient clinics to have POCT devices. And when they don't have a POCT device or a regular checkup centers, the patients don't undergo HbA1c testing. So next time I'll get the report. When is the next time you are prescribing medicines to this particular gentleman without doing an HbA1c, without knowing their status of HbA1c? So this is the real world challenge. The moment you have a point of care testing, the whole scenario completely changes in front of the patient. Like we have the example in front of you. So role of point of care testing in diabetes, if a patient comes to your clinic, you can do all these simple tests. in 10 to 15 minutes time, and your reports is in front of you. The patient feels very good. A patient is working in a bank, he takes a chutti for 30 minutes and 1 hour time, he comes to your clinic, he gets everything done and goes with a prescription. He feels very, very satisfied. The moment you tell him, come tomorrow morning fasting and we'll take your sample of fasting for lipids and fasting blood sugar and everything, sir, kal fir chutti lena padega kya? Then you will ask him, come in the evening for your reports and another consultation in the evening, and 2 hours later for your post-pandal. Doesn't help today, you know. The compliance becomes very, very poor. And I tell you, this is what is needed today in chronic care. Services providers and technology should go hand in hand. And that is how patients' compliance and adherence is going to help. Because the next time follow-up, the patients, you know, you heard in the last lecture, patients आते नहीं, 50% patients clinic में follow-up नहीं करते. Why? Because of this cumbersome nature of follow-up. Patients है, अरे डॉक्टर के क्लिनिक में जाएंगे ना, फिर वहाँ 2 दिन 3 दिन का छुट्टी लेना पड़ेगा. You understand? So that type of mentality should not imbibe in the patient's mind. डॉक्टर के क्लिनिक में जाएंगे ना, 1 घंटे में सारा काम हो जाएगा. That comfort should be there in their mind so that they have a good follow-up. Opportunities for POCT in diabetes clinic is also very important. You can do a routine blood glucose self-testing. I remember when we started using glucometers in our clinic, I'm talking about 20 years down the lane. People used to say, these are not very, very reliable, go to the laboratory and get it done. But when you used to pick up hypoglycemia and correct it immediately, then they used to accept that a particular device is good. So that is how the opportunistic people are in. The moment you say the blood sugar is 500, this is not a good device, go to the laboratory. The moment you say you have a good reading, everything is fine. Similarly with today we do ambulatory glucose monitoring. You get the data is good, the device is good. You don't get good data, the device becomes bad. Yes, blood glucose is done by capillary method, precision, accuracy, and user acceptance. We have Dr. Amit here to talk on this a little later. Structured SMBG, precision is there. In repeatedly, there is a data from One Touch which says that the variation is very, very less. In the lower values, the CV is less than 5% and the standard deviation of less than 5 milligram per deciliter. And in the clinical accuracy study, 100% of measurements were with less than 75, were between plus minus 15 milligrams. So it's almost as good as the laboratory data. And 99.6% of measurements with more than 75 and less than 200 were within plus minus 20%. So it's very, very accurate today. And the select simple BGMS met all criteria for precision, system, and user accuracy, was easy to use and was well accepted by the patients. And we all know the advantages of SMBG. I'm not going to talk much on that, but it improves the blood glucose control. It has become one part of almost all the patients on insulin therapy, in pregnant ladies, in type 1 diabetics, because less time is lost between recognizing symptoms and confirming blood glucose levels. 5 seconds. Patient gains independence in diabetes management and helps patient to learn and understand decision-making process. Similarly, urine testing is very, very simple. We don't do much today, but we do use a keto diastics. I always ask my patients to use a keto diastics who have a poorly controlled diabetes to look for ketone bodies, especially in type 1 diabetes. And the limitations and the uses are, it is significant in diabetes mellitus and renal glycosuria, but today patients are getting drugs like SGLT2 inhibitors where you can have falsely positive urine glucose with normal blood glucose values. Limitations are interference, reducing agents, especially vitamin C. Today in COVID time, every patient is taking 2 to 3 tablets of vitamin C, ascorbic acid 500 milligram, immune booster drugs, and that is how you get falsely positive urine sugars as well. POC HbA1c is very, very popular today. I am sure most of us are using it very, very comfortably, very easy to use. You take a sample, you examine a patient, you do everything. By the time everything has been done, your reports are ready in front of you. Ready to use reagent cartridges that can be inserted straight into the analyzer. Blood samples are added directly. No need for pre-mixing or pipetting. Minimizing the number of steps in the procedures. Procedure reduces user error and standardize results by eliminating any variation introduced by different operators. We usually use this boronate fluorescence quenching technology in Afinion LR meters, which we use commonly in our clinics. and it takes 3 minutes is the assay time. 1.5 microliter is the sample volume. You can understand very little blood is being needed. Whole blood samples are used. Configurable measuring units. Measuring range is 4 to 15 HbA1c. If you have HbA1c more than 15, it's like high, like your glucometer, you provide more than 15%. But the good part of this meter is if your hemoglobin is less or your hemoglobin is high, it detects it and tells you that your hemoglobin is less, so it doesn't give you an HbA1c value. You can send the patient for anemia check and you'll get the report immediately. Similarly, for higher HbA1c, higher hemoglobin values like more than 15 or 16, it picks up and says you have a higher hemoglobin values. This is how it looks like, the Afinion 2, the newer one. And the good thing is it actually takes care of not only HbA1c, albumin creatinine ratio, the lipid panel, the CRP panel. Recently they are going to come up with the anti-pro-BNP panel as well. POCT leads to better HbA1c reduction compared to lab, both in long term and short term, and we are experiencing in clinics as well. Patient just comes to get their HbA1c done in clinics and they just move on that the HbA1c is good. They enter the clinic, get their blood tested and move on. So that is the type of advantage we have with this point of care centers. And use of POC testing for A1C provides the opportunity for more timely treatment changes. Today, the ADA suggests that if a patient is having a good control of diabetes, at least 2 to 3 HbA1c should be done, 2 minimum HbA1c should be done. And if a patient is having a poorly control of diabetes, every 3 months he should undergo a HbA1c till his levels, targets are been achieved. So that is the type of recommendation which is coming up. Similarly, for microalbuminuria, we have a POCT device. The same device, we have a different cartridges we can use for microalbumin. We have a test strips as well which are available. This we used to do when we were doing post-creation in our hospital. We had these strips in our ward and we used to routinely follow this. Similarly, we have from Siemens the Clinitec microalbumin reagent strips. So the important thing is the ACR test strip showed high sensitivity, specificity and negative predictive values, suggesting that the test can be used to screen for albuminuria in cases of pre-diabetes and diabetes. You get an idea in front of you. You can immediately tell your patients to take care of it. You can repeat it after 3 months. Even the ADA says you should have 2 microalbumin positive in 6 months time to actually say that this patient has got nephropathy. And you should rule out UTI. 1 or 2 minutes, yeah. Similarly, for lipid panels, we use these meters like point of care devices. The Cholestech LDX is the one which we are using it, and it comes with a very handy device. And the lipid profile can not only be just a lipid profile, you actually get all these readings incorporated, and finally you get a CSD risk calculated in percentage of algorithm by Framingham Heart Study. So this is another advantage with this. Similarly, we do a ketone test. The urine dipsticks test is very, very popular. We commonly use this. The ketone bodies detection is also has limitations. Like significance is like diabetes, ketoacidosis, prolonged fasting, and even patients on SGLT2 inhibitors can have ketones positive. Euglycemic ketoacidosis is known with SGLT2 inhibitors. The limitations, as we discussed, are interference. We have a device to look for even blood ketone bodies, which is not commonly used. Only when you are using this meter, you can use this device. What to expect with ketone meters? The sensitivity is again very, very good. The accurate results in 10 seconds. And we have to be cautious in people who are on low carb diets, and experts have not reached an agreement as to what high is too high. So these are the benefits obtained by utilizing POCTs, operational benefits, clinical benefits, economic and patients benefit as well. And POCT improves patients and healthcare providers' communication and collaboration in diabetes management. They understand right in front of you. The important thing is a very transparent system. Patient sees in front of them that their blood has been utilized and the report is in front of them. That's the most important thing. In the bigger laboratories, they feel sometimes that sample got mismatched and it's not possible. My fasting was 110, my PP was 180, how can the HbA1c be 9 and 10? So again, that is an advantage with POCT. There are some issues with POCTs, but training has to be good. So to summarize this, simple and accurate POCT can help overcome barriers and reduce compliance with testing frequency. And this has become a holistic approach to diabetes care in many countries and many healthcare organizations. POCT can improve patient satisfaction, foster a stronger patient-provider relationship, and motivate patients to be more involved with self-care. Implementation of POC testing also helps to elevate the burden of diabetes on providers by streamlining operations and creating efficiencies within the practice. Accuracy and precision of test is still a challenge, hence utility of POC as diagnostic purpose needs further validation. Like for glucometers, we say no, you can screen a non-diabetic person with a glucometer, but when you have in doubt, ask them to go to a laboratory and do an OGTT or a 75 grams glucose tolerance test to actually pick up for diagnosis of diabetes. Similarly with HbA1c in POCT, if you have someone with a HbA1c of 9 or 10, you need not even confirm it. But someone having a HbA1c of 6.6 and 6.7, you can get a second test by HPLC method, which is the gold standard to confirm it. So that is the type of validation we need. But improved clinical outcomes increases the recognition that testing plays an important role in the management of diabetes and related complications. So I thank each and everyone for their patient listening, and I thank the organizers for this opportunity. Thank you.
Thank you, Doctor, for this informative lecture. And let's proceed to the second lecture.
We've already introduced Dr. Mohammed, so we'll start with your presentation, sir.
Very good evening all. Thanks for the opportunity thanks to the organizer for getting me an opportunity to share the insights of the latest technology which we had invented. Would love to talk about reversal and remission of chronic diseases. And to start with, let us look at the data. So this is the real data from our 1-year randomized control trial, which has been run for the past 18 months. And our percentage reversal at day 360 is 94.1%. And based on the recent consensus statement by the ADA and other authorities, where we more talk about remission, where 6 months intervention and 3 months no medication including metformin, our reversal rate stands at 79.8. Mind-blogging results, isn't it? So how is it possible and what made it possible, right? And it is all, we all know that the entire community, doctor community, you had been living and breathing with knowing that diabetes by itself is not a disease, it's a condition, and the main problem is the disruptive metabolism. We did not have a mechanism to precisely measure because of its complex nature and the dynamic nature of it. It keeps changing often, right? Every minute it continues to be changing, and we did not have a way to precisely measure it. That is where Twin started to work on it, because the other founder had a experience solving for an automobile. Tesla was powered through a technology where through the concepts of digital twin, they were able to diagnose the automobiles. The entire automobile community was powered by an IoT platform called Jasper. Based on that initiative, we had come out with a novel technology where Twin comes out with a solution where we want to retrack and ensure that we take the body back to a normal state, wherein we are working towards a condition where members starts to get back, reverse this condition. That's where we had worked. How is it possible? We all know metabolism is also so messy. Though if we say it's a simplified view, it is even messier than this, right? And we are trying to create a whole body digital twin of a human. With advent in technology, a lot of sensors which are coming up with artificial intelligence, machine learning into existence, we are trying to put basic sensor on human body, collects data. The ML requires 3 or 4 data points, and continuous correlation of it can make a digital twin. So what we do is we typically put 3 to 5 sensors depending on the body's condition. We do every quarterly blood test. Comprehensive blood test starting from CBC to testosterone of a human is collected. The lipid profile, the renal profile, all the blood tests are collected quarterly. And in addition, we collect causal data from the human. We ask the member to log in their mood, energy, what they eat, what they like, dislike, all those are collected. And by every day, 3,000 data points are collected through the sensor data, and it correlates across all these data points, does a computation of 1.4 into 10 to the power of 104 computations. Just imagine 1.4 followed by 104 zeros of such a huge computation takes place, by which it tries to create a pattern and tries to come out with the innovative solution of creating a mimic of a human body. So the innovation here is we had come out with the whole body digital twin, which is able to offer up and understand the root cause of the problem, which is nothing but the damaged metabolism, and it is highly individualized because we all know every human is unique, and the way each human behaves is completely unique. And with the advent of technology, the world is moving towards offering precision treatment. So here the whole body digital twin, the innovation is to make doctors super powerful, to make doctors offer precision treatment, to see doctors offer a better solution holistically, and it is dynamic completely and accountable. That's very, very important, because ultimately doctor wants solutions which are accountable, which is proven, right? And the solution that we offer should be sustainable. It is not just someone reverse today and it goes off, right? It needs to sustain. That's very, very important. That's what it is. And when we spoke to doctors, we asked doctors, after we rolled out the technology in India, we asked a doctor, your patient has reversed, how happy are you? What will make you even happier? He said, the first thing that I want is, I want my member to be happy. The health comes next. I want my patient to be happy. And that is where we started to use technology to ensure that we make the coexistence of happiness and health. And that is what the technology has made it possible. It is nothing but through atomic experience, smaller experience, can we offer through micro actions and micro feelings what is need to be done. That's what is the power of technology, because we keep telling behavioral change is challenging. It's not so easy. So here what we are trying to do is, we have built this technology to ensure that through atomic experience, through micro experience, can we offer the outcome. And that is what has made it possible. Through simple repeatable action, but it is dynamic real-time insights. Member is able to see the real-time insight of what is happening in the body. That's more powerful. So we all know, how are you doing? You may say, I'm doing great. But can you precisely tell how good are you doing? With data points, with health data points. Someone will be healthier, but all of a sudden that night he collapses. But here technology makes it possible that he knows where his body is. He knows what is his condition, how well is his kidney functionality is. That is the power of technology which is making it possible. And as I told you, whatever outcome we deliver, it should be sustainable. That's what doctor loves to be, right? So look at, right? And that's what we try to offer. We start with engagement, onboard the patient with doctor and a care team. The care team encompasses the primary doctor, a junior doctor alternate, and a coach for every patient. And it's a journey. It is not an instantaneous action. It is journey and he tries to get an healthy for life solution. So how is it possible and what was the technology behind it? So as I told you, set of sensor data, lab diagnostic data and the causal data. We try to build a whole body digital twin, first of its kind. It's a patented solution. And in addition to that, what are the treatment factors that make it possible? It is precision nutrition, precision medication, precision activity, precision sleep and meditative breathing. This is what makes it possible. And almost 70% of our patients are able to stop their medication in less than 60 days of time. That's something which is very, very amazing that we are able to see. And we have proved that it is phenotypic independent, because the solution is precision to the individual's body's condition. So it may take a longer time for some body, but for most of them it tries to offer the solution. When I talk about precision nutrition, you may be wondering, is it yet another dietary program that this company is trying to offer? Of course, no. It's not a dietary program, it's a healing program. Someone cannot follow a diet for life. It's practically not possible. So ultimately, as the member is offered a solution, Dr. Shanmuvel was talking about the importance of bioterm, the importance of the dietary program and other stuff. At the end of it, when doctor asked, is there data to be understood about what is it? And we all know there are multiple factors which are there. Deficient of it is also bad, excess is also bad. It is toxic on either ends. So positioning depending on the metabolic condition of the body is very, very important. It is not that rice is bad for all. It is not that wheat is bad for all. It is personalized to individual, depending on the metabolic condition of the body, which is very, very important. Precisely when you offer the solution through factoring the 87 factors that are available in the food that we eat, because most of the dietary program looks at the macronutrients in a big way. But the macronutrients are only a source of fuel to the body, and the actual energizing factor are the micronutrients and the biota. And through the high definition database which we had built for more than 1 million food items, capturing all the 87 factors, which has made it possible today. So through precision nutrition and activity, people say, you go do walking, and people are there to say that you lose weight, you normalize sugar. It's not so. You normalize today, but tomorrow what is it? Right? You need to sustain it, that's very, very important. Fatiguing the muscle precisely to improve the insulin resistance is very, very important. So understanding the body, the whole body digital twin precisely recommend what kind of muscle metabolism has to be done, what kind of movement has to be done to improve the insulin resistance. And sleep, something very, very important. In order to regulate the sleep of the hormonal impact, which is very, very important. So sleep recommendation is very, very important, precisely understanding the body's condition, by which we are able to retrack it. So for everything there's an engine built. So this is the AIML model which we had built. This is a patented solution, and this is what has made it possible, what I am talking about, right? And we are literally trying to understand, map with the timeline. How does the body moves? Because metabolism keeps changing. So we capture the entire factors under timeline and try to factorize it and offer a solution which is making it possible. And how easy it is or how difficult it is. So the initial stage of the treatment, what is required is the member needs to spend 6 minutes in this app. Maximum 6 minutes is what is required. And as the whole body digital twin matures, when he gets into the platform, he tries to find out his peer, almost the same, though it is not the same, across the twin, millions of twins are created across the globe, and offers a generic solution. But as it matures, it starts to mature, medications goes off. Sensors gets reduced. That's the novelty of what we are trying to do. The whole body digital twin has the capability to predict sugars. The whole body digital twin has the capability to predict hypertension. The whole body digital twin tracks the kidney functionality. And all these at an accuracy of 97%. After 35 days of time, CGM patch is not used. People think that with CGM patch they will be able to reverse diabetes. It is not so. We are not looking at sugars as sugars are one of the factors into the digital twin. Our focus is to go heal the root cause of the problem, which is the disruptive metabolism. Right? People look at sugar in a big way. Sugar, say a simple example, if you want you could try it out. Put a CGM patch, eat the same food, same time daily. Do you think the sugar response is the same? 100% no. And the difference is huge. Right? But people think that is the solution, but that's where we tell, don't look at sugars. Sugars is a byproduct. What we need to look at it is we need to look at the body holistically. And that is where we are able to eliminate things. And as the digital twin becomes matured, even the food log is not required. The member has to wear the watch and use the body composition monitor daily morning, that's it. By which the digital twin starts to understand and start to offer a right solution. And this is the deep learning of what is making it possible. How the learning happens is what I'm trying to depict here, sure. So, and this is what is very, very interesting. You could see here, we had picked up 50 patients. And we have picked up around 8 parameters, 8 factors. At a time, look at how the body behaves. Somebody wants more of sodium. Somebody wants more of activity. Somebody wants more of sleep. And the beauty is, this keeps changing. That's what is very, very important. And dynamism makes it complex. And that's what is making it very, very powerful. Right? And this is what I told you. The way every body metabolizes is totally different. You could see here, right, we had lensed it and shown. So across 50 members, every food item is captured as dot. When it is green, the body is able to metabolize. When it is red, it is not able to metabolize. But the beauty of our treatment is when the member gets into the platform, you could see here, when the initial stage, most of the food items are red, intolerant. As he has yielded his metabolism, the food starts to become green. The digital twin understands on the day of enrollment the food which are intolerant, and as he heals the metabolism, the platform starts to recommend the food which was said now red in the early stages, because he has healed his metabolism, by which he goes back and start to eat his normal food. That is what is making the power of what is it true, right? So how does each body behave is what we are trying to show here. Already she has told 2 minutes, so let me wind it up. And Netflix and is one of the biggest player on the prediction. You look at the comparison, already our prediction model has overtaken what Netflix is able to do, right? That is the power of technology. So these are some data points to show you, and let me quickly run through things. This is what I told. This is the actual data of a CGM patch. This is the actual data of a CGM patch, and the pink line depicts the prediction of the whole body digital twin. After the CGM, the digital twin has learned the body, it starts to predict the sugars, right? And by which you eliminate the requirement of the CGM patch, and you look at how does the glucose, and look at what Google's prediction is and where twin prediction is. Far, 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 far superior to the prediction model what we had built, right? And this is what is hypertension prediction, right? And retina prediction comparison. All these are proven scientifically and published as data. And as I told you, this is the kidney functionality. We track the kidney functionality too. And what do? We really build a network of twin. Every twin, every body understands each other and talks to each other to make ourselves better. And the solution is offered by which we are able to precisely, and these are the patents that we had acquired so far. And very proud to share that, though we have an embargo, but this forum I don't mind sharing. 3 of our papers that we had submitted 3 papers to ADA. All 3 papers got accepted in ADA, invited for presentation. And adding to it is, they had identified our technology to be unique and revolutionary, which is going to make a huge difference in the mankind. And ADA has requested us permission for doing a media press coverage, and already we had given acceptance for it. So you will start to see ADA talking about whole body digital twin before ADA initiative started. And all these are scientifically published. All claims are scientifically published. And as I said, though this is a diabetic conference, I have spoken about remission and reversal, we see gamut of change happening in the body. We are able to reverse hypertension, we are able to reverse dyslipidemia, we are able to reverse multiple things. So these are things which are there. And based on what we had learned, we had initiated RCT on hypertension and NAFLD. And you could see these are the data which we are seeing regulated after a year of the whole body digital twin intervention with patients. So thanks for the opportunity to present the technology to this forum. Thank you.
It was really, really interesting to look at how Twin Health is actually working. So with that, we leave the rest of the questions for the discussion part, and we have our very own Dr. Banshi Sabu sir. Sir needs no introduction. He is my mentor, and I would like to really say that he has a lot of feathers in his hat, starting from being the current Secretary for Diabetes India, and then I'll say he's the president for, immediate past president for RSSDI. I can't name an organization where he's not in one of the elite panel. And okay, he's a clinician, an academician, a scientist, a researcher, and I think I'm out of words, or I'm out of adjectives. So over to you, sir. You know, most of the public co-author, all the 3 co-author for ADA, there.
So what I'm going to talk on a connected blood glucose monitoring from evidence to clinical practice. Before I make my presentation, I just want to make that this is the technology workshop which we are doing. And before it also there was one more 1 hour technology on continuous glucose monitoring which we have done. And what we found that a technology usage in our country is really less. And I'm sure those who are practicing diabetes, and many of us are using technology in a different format in our country, but still the uses of technology at a primary care or even at a consultant level is still very less. And what should we do in the future? I think we should have more and more uses of technology to improve the care for diabetic patients. That is what our vision is. And with that vision, we have started a diabetes technology, a dedicated meeting only on technology. That's what we have started. It is definitely a technology is a part of all big meetings, whether it's a Diabetes India, RSSDI, or across the country in last decade. You go and see any meeting, you will find 1 hour, 2 hour. But what I had seen that technology workshop is in workshop room. It is not in the part of main hall, not in the part of the main program, and that's what we had seen. And still those who are coming in the technology workshop, they already use the technology. So it should be used by more physicians with more doctors, and that's the reason we had thought of to start a dedicated meeting on a diabetes technology. Shashank have come for the twin technology, you know. Just one look, I know you have come for him only. I know, but unluckily, I'm the speaker now. He had already finished his talk. So we have now dedicated meeting also on diabetes technology. So the next time it will not be in the workshop, Muluk. You are there already in our dedicated meeting of diabetes technology, which was there for 2 days. Amit, Shashank was the advisor, and many of you, even Mithun and everyone was the part of it. I'll be finishing in next 15 minutes on a talk on a connected blood glucose monitoring from evidence to clinical practice. I have a disclaimer to make here that it's supported by LifeScan, so I'll be using their slides also for that. The current challenges in diabetes care is worsening patients to provide a ratio that we know that number of healthcare professionals to take care of diabetic patients are less in our country. There are geographical barriers to assess the care. That's also very important because the rural part of our country is still not able to get the best of the doctors. The patient burden is very, very high. The provider burden is here high because they have to see a lot of patients. I mean, those who are practicing dedicated practice, they have to see a lot of patients. There is an economic burden also. It's a huge economic burden for the patients and no improvement in outcome because still the average A1C of our country is more than 8 or 8.5 and still we have highest number of complications with diabetes in our country. So I mean, there is no improvement as far as outcome is concerned for our country. We all see the ADA guideline, but we forget to see the right part of that tabular format, that is a patient-centered approach, which they have put in the tabular form, that it is the, not the ADA guideline does not mean only the therapy guideline. It is the patient-centered approach that is most important part of it. If you see the complete booklet, they talk about the goals of care. The goal of care is to prevent the complication. Why we are treating the diabetic patients? For prevention of the complication. And second most important thing, to optimize the quality of life. These are the two most important things. You are treating diabetic patients not for anything, for preventing the complication and for better quality of life. So whenever a patient is there, we have to assess the patient. We have to plan the treatment, whatever we are deciding. The management plan has to go upon it. We have to agree with the patients, which is not there in our country. We just write it. It has to be implemented. But the most important thing is the monitoring of the plan. And I think where we are lacking. We write the patient treatment, but we don't monitor it, neither by the doctor nor by the patients. Patient come after 2 years, 1 year, 6 years, 5 years with the A1C of 9, 8.5. In between, they might have checked up their A1C. They might have done their even sugar report also, but it is always high, and they have not done any monitoring. So I think the monitoring is something which is completely lacking in our country, and it is one of the important and responsible reasons for us to have a uncontrolled diabetes in our country. The blood glucose monitoring is a fundamental component of a diabetes care. We educate the patient, we do assessment, we optimize the therapy, but ultimate outcome of the patient is not able to achieve a good glycemic control because patients are not monitored frequently. And this is a real fact. Even after 20 years of self-monitoring of blood glucose in our country, we ask our patient to buy the glucose meter. They do it very occasionally, not very regular basis. They have the glucose meter, they have the strips, they even some of the patients do even A1C also, but they don't go to the doctor to show that report also. Probably we are not educating them enough for monitoring part of it. The self-monitoring of blood glucose, HbA1c is perceived as a gold standard for monitoring glycemic control and serves as a surrogate for diabetes-related complication. All the data which we have. We know that now we started using the time in range, but it's only for those patients where you are using continuous glucose monitoring. You can't think of for each and every patient, and that's what the new term for patients who are using self-monitoring of blood glucose. You can think of points in range, if not times in range for that patient. It does not provide information about day-to-day and intraday changes in glucose level. I'm sure we all know that the HbA1c is going to give you the only average glucose level. It is not going to tell you, nothing going to tell you about intraday or intraday changes in the glucose level. Self-monitoring is important because it can distinguish fasting, preprandial, postprandial, detect glycemic excursion, identify and assist monitoring resolution in hypoglycemia, and provide immediate feedback to patients about the effect of food choice, activity, medication on glycemic control. And somebody may argue, these all you can better do with the continuous glucose monitoring. I agree with that. You can do all these things with a CGM, but still those you can't have, and we know that everyone can't have the CGM. Still CGM is not recommended by AS and ADA. For type 1 they are recommending, not for every type 2 diabetic patients. Probably less data is available, the evidence is less, and we want to have more of patients on a self-monitoring of blood glucose which have more data in compared to, and which have also other advantage of distinguishing these patients and to get the data of fasting, preprandial and post meal also. Now, what is most difficult thing? I think the patient does not come with a meaningful monitoring. The structured monitoring is not there. Many of these patients, they come with a rough pad and they just write 10, 12, 15 reports, occasionally done, randomly done, not doing the sugar monitoring as per prescribed. And a busy clinician, he does not want to see even that ganda paper, you know, which is written with hundreds of reports is written on that, and he does not want to see, he does not want to spend even few minutes for that, and this demotivates the patient. I mean, if your patient had shown, because he has done multiple times the sugar report, he had pricked it and he tries to show to the clinician, see, I have done 100 times the sugar, my this was this, and then okay, it's fine. So he just tried to see the HbA1c and he just tried to medication on that. So this demotivates the patient, and this is also one of the reasons why our patients are not doing self-monitoring of blood glucose very regularly. So we have to make our SMBG very, very structured. We have to make it very, very meaningful, and that's very important because that is going to modify their behavior. If we write everything in a very proper way, that how many preprandials, post meals, random, midnight, and everything is written in a proper way, or you make a graphical presentation of that, or either by some way or other way. And for that, I am going to talk that what exactly the meaningful monitoring or what the structure monitoring is there. The structure intervention will definitely have a better outcome. This is what we do in our clinical practice. I mean, in my clinic, when we give the paper like this, you can do, because each and every patient is not doing actually 7 times a day. I mean, even a type 1 diabetic patients also, we call them 3 times a day you do before meals, and then you check your sugar and take your insulin accordingly. Once in a week you can do 7 times a day, sometime weekend, sometime weekdays. That is what we try to do, and we get a structured intervention, because this will show you that where the sugar reports are up or low. But ideally these patients should be also empowered, because if there is a high or there is a low, they should also try to do on their own, because that is also what we should do. It's just not just seeing their reports. If they have a 56, then what they have done, you have to empower the patient to do all those things too. The pattern analysis will give you the idea that where the patient sugar is getting high or low, and that will very important, because that will decide your diet, that will decide the exercise, the pattern, everything, all the aspects of the diabetes care which can be done, because the structured intervention will definitely help for these patients. These are the protocol. This is that acting based on the patient is the change is necessary and the responding to pattern. So whatever the patient had done, suppose in this week he had seen whatever the changes which was there in the post meal, and he has changed his diet accordingly. The next week he can see on his own also that these things are really making difference in his life, and that is what whatever the action which he takes, the patterns will change also. Now, how connected blood glucose monitoring is a tool for remote monitoring. This is what the point is, that the self-monitoring of blood glucose over a period of time, it also evolved. We know that simultaneously a technology of continuous glucose monitoring had come, but the blood glucose monitoring also evolved in last 20 or 30 years. Till that it had come with a very small amount of the blood. Now you can have very prick is also almost penless. You get very small amount of the blood and still you can get connected. The glucose meter now connected with your device. It is also been remotely monitored, even not only by your doctor, but also remotely monitored by your, the relative and even the friends also. If you want to remotely, somebody wants to monitor you, that what's your sugar level also. So this is how the new generation connected blood glucose monitoring devices work. The patient monitor their blood glucose on a Bluetooth connected one touch Veroflex meter. I am just here, again I told you this is the live scan, so I am using their slide to talk that this is their brand, but there are many other glucose meter which are also connected. So they can be connected with your smartphone and the blood glucose data get automatically transferred once they get synchronized on a mobile app. It is also in a graphical form, so your doctor can also get the complete on a web page that how the data looks like. In between contact with the SCP, patient continues to monitor their glucose value using their meter and may gain further insight using this mobile application, which are again available with different glucose meter system, and healthcare professional can access the patient data remotely between the visits on one touch reveal web app that can connect the patient if needed. And again I am telling with other glucose meter also this type of web application is available. So it's not necessarily that only with one company it is there. So my point is here, this connected glucose meter, how they can help the patients and healthcare professional as well as their relative also. It reveals the complete ecosystem. Now we know that at least one part of it is very important because it also gives you, if some patient is doing multiple times monitoring, it gives you the graphical presentation, and that looks very, for the healthcare professional. Once you see that report like what we see in ambulatory glucose profile, when we were doing before Abbott Libre had come, the Medtronic was there with a continuous glucose monitoring, but it was very confusing, and that was also one of the reasons that CGM was never interpreted, and the Medtronic continuous glucose monitoring nobody was using. And once the ambulatory glucose profile in this format it had come, we all started using it because it becomes very easy. And similarly, you can see a similar type of graphical presentation when patient is using a connected glucose meter, and it actually reveals the complete ecosystem. And for a healthcare professional, it becomes very easy that where the patient going sugar above or low, it gives you like graph like a time in range. We may call it points in range because it's not continuous monitoring how many times the patient have done. Suppose in a week time, if it is done more than 20 times, you can find that out of 20, like if the different times of the day, 15 is done, it is like 75% of the time it is points in range. So that is what it is done. Oh, sorry. So one touch reveal patient app, this is, it looks like this application. I am not going into detail because you can see also. This is the how the different multiple times the patient is monitored. These it will come in this graphical form, which becomes also very easy for the patient, and he can also write the event. Event is very important because whether it is pre-meal, post-meal, pre-exercise, post-exercise, for doctor to understand, it's very important. He can share the report, and that sharing the report will also give the green and red and the blue, that's color coding is there, that how much time the person's sugar was in the control. Also, if the web app for the doctors also becomes very easy because he can see how many times the patient have done the sugar and how many times the patient sugar remains in the application, in the time in range, will ensure a meaningful diabetes care, because that is what more important. Just to get monitoring is not sufficient. It is the meaningful monitoring. Now here I want to put two words. The structure monitoring means how structurally you are doing, and the companies have made job much easier because by getting the app and by getting the web page, you can see this structure monitoring more. But meaningful monitoring means the patient who is doing the sugar report, he should also understand what is the report meaning. If it is 164, it is 254 or it is 64, he should also understand that this is 54, what he has to do. So the action plan we have to give the patient. That is what the empowerment of a patient is very, very important, and that is what the meaningful monitoring for this. This is one of the data which is randomized control trial with 5 UK sites, 121 patients with type 1 diabetic patients. I am not going in the detail of methodology. I am just putting the data to show that key outcome of the study with 1% decrease in the A1C and 10.4% increase in the number of blood glucose value. So if you give the structured monitoring and meaningful monitoring, even patient also get motivated to do more and more monitoring and to get that. In a clinical setting, in a case study where a 65-year-old female lives alone, post-hospitalization, patient was put on a basal bolus insulin, and patient was getting her sugar, and simultaneously she was also titrating her sugar report, and at the same time as she was not going to the clinic or hospital again, and the blood glucose monitoring can be reviewed remotely from the doctor's clinic. So that's an advantage that you can use for your patients who are on basal bolus and they are remotely, they can be monitored if they are living alone. So this is what we can do from this. To summarize my talk, blood glucose monitoring is a cornerstone for the management of diabetes and help healthcare providers to assess the glycemic control, adjust therapy accordingly, and help patients to modify lifestyle accordingly. Structured monitoring, pattern analysis, and specific action based on pattern provides better control on both hyperglycemia and hypoglycemia. Patient and physician connected blood glucose monitor eases the burden with the logbook maintaining, data sharing, evaluating blood glucose reading, and remote monitoring. With this, I thank once again. Sorry for some more time. Thank you very much.
Thank you, doctor, for giving an insightful lecture on monitoring. And we move to the last topic for today by Dr. Amit Gupta. He's a director for Center for Diabetes Care from Greater Noida. He's an apex body member of the Art of Living Trust, a reviewer for multiple magazines.
So almost 70% of my talk has already been covered by Bansi Sabu sir. So I am left with only 2-3 points which I would like to drive home. No sir, you have made my task easy. So I will particularly focus on point in range and how we can make SMBG data more structured and helpful. Because when we were searching for point in range publications, we couldn't find many. And this was this again shows that this is an area where a lot of research can be done, and we can actually publish a lot of data. And this is something which we do regularly with our patients. So structured self monitoring of the blood glucose, sir has already talked about, and we will talk about the point in range. I think slides. So I will not go into the details of what SMBG is and how does it helps. We all know that one of the problem which we have identified is that there is trouble in spotting the pattern. So whether it is a CGM, whether it was a earlier Medtronic devices or the newer CGM devices, whether it is the diary of the patient, the logbook, or the data even which is captured in the apps. So there is always a trouble, and most of the time, as rightly pointed out by Bansi sir, we don't pay too much attention to the data. And this is also discouraging for the patient. So what can be done? Is there any way to look into this? So why don't clinicians utilize SMBG data? There is insufficient information. Sometimes the patient does not bring the data in the way you would like to see. So you have ordered something, you have requested something, but the patient is often checking something else. We are not able to educate and train the person. Many a times it happens that you have given a glucometer, and after 3 months the patient will simply tell, even after buying the glucometer, patient has not tested because he simply couldn't deal with the glucometer or handle the glucometer wisely. So many a times the glucometer is there, but the person is not using. Also, sometimes we overestimate ourselves that we have given the treatment, the patient will be fine. So there is no need for monitoring, and the patient will, the next time the patient will come, it will be okay. Difficult to analyze the data, poor time which we devote to our patients, and there is also sometimes there is a fear of adverse events like hypoglycemia. If patient monitors too frequently and the patient gets very variable sugars, then the patient will reach out to you, whether it is a hypoglycemia or hyperglycemia. So a patient who monitors more frequently is likely to reach out to you more and more. So at times you may feel that it is again a trouble for you. because you may not like to respond all the time to the fluctuating sugar levels. So again, this is something. So there is a vicious cycle. We know that there is a lack of patient SMBG performance, there is unrealized SMBG value, and there is lack of clinician SMBG utilization. So what is structured SMBG? Structured SMBG is something that monitoring blood glucose at the right frequency, at the right times, and in the right situations. So if we look at this, what are the benefits of the structured SMBG? For the patients, the structured testing means that it improves disease awareness. It also improves the ability to recognize and estimate impact of certain behaviors and active participation in the therapy adjustments. For us, what does it means is that we get more reliable data, and we are able to analyze the patterns, and we can adjust the drugs and the therapies. Also, there is a better compliance and more active involvement of the patient in the care. So the patient becomes a partner in the care rather than just the receiver of the care. So this is just a flow showing that when we ask the patient to do a structured testing, then we analyze the pattern, then the treatment decision is taken, and the treatment decision is then implemented in the form of action, and then we see what happens to the patient. So prior to the 2001 STEP publications, there was a growing body of evidence which was beginning to demonstrate the beneficial effect of structured blood glucose testing, and I will not go into details. There are many publications which are there and clinical studies on the structured SMBG. So this is one of the slide which shows that this is in which the structured SMBG pattern was done. And what happens is that when you do it in a structured way, it was seen that it actually improves the patient's HbA1c, and the other parameters also improve. When Dr. Maluk was talking, he was getting thousands of data at a particular point of day or a particular point of time, and then they are interpreting it by means of AI or the deep learning or the machine learning. But here what we are doing is that we are managing our own data. Many of the times the doctors also don't feel comfortable in entering the data in others' app because of the fear of some data privacies and the other policies. So it is very easy to make your own app also, where you can ask the patient, the data doesn't go anywhere, data remains with you, and you can still get these patterns and analysis where the manual feeding can also be done. Even if they are not using any advanced glucometer, then it is something which is very simple. This brings to me to the second part of my talk, that is the point in range, which we wanted to highlight in this. We all know that there is a time in range, time above range, and time below range, and a lot of talks are happening, a lot of symposiums are happening when it comes to CGM and all this. But there is something called PIR, that is point in range, the point above range, and the point below range. And this is something which we can get very easily from the SMBG data of our patients. So there is a limited evidence that the blood glucose values measured with SMBG can be pooled and expressed as TIR, TBR, and TAR. So we have also seen that simply few measurements, they cannot be correlated with TIR, and they cannot be correlated with the CGM also. So you need many data points. So PIR or PAR or PBR is something that is in between TIR and the SMBG alone. So it is more than SMBG and less than CGM, but it can again help us in getting better understanding of the patient's data. So this is just a very slide. If you look at this data carefully, this is one of the dashboard from our own patient. And if you see that this patient is regularly checking the blood sugar level, this is from the 8th Jan, and you can see the last measurement was on the 19th of May. And you can see this is very well self-recorded and transferred to us through the app. And you can see that most of the time the patient's fasting glucose is less than 130. There are some points where the patient is touching, going above 130, but most of the time the patient is below 140. So in a one glance, you can make a meaningful interpretation of the data. And the patient is also happy that you have seen all the data. At the same time, this also gives you some sense of prediction before you order the HbA1c. You will see that this patient is likely to have a better HbA1c because you have seen so many data points in the last 3-4 months, and the only just few times the patient was above 130, which is the ADA target that we target for less than 130 milligram per deciliter as per the ADA recommendations. Similarly, this is the data from the same patient where you will find that they have recorded pre-meal glucose levels also, but less frequently, but in a more structured way. You will see, if then you will find that the patient is monitoring almost every 15th day, sometime more frequently, sometime less frequently, but you will see that patient is below 180. Only once the patient was above 180. So again, it gives you a snapshot that again this patient is likely to have a good control of blood sugar because you have seen so many data points. This is the post-meal blood glucose of the patient, and again you will find that if you look at the data from the 30th March to 21st May, you will find that most of the time the patient is below 150. So this is what the point in range means, and the patient is doing a regular testing. So can we do some more research to bring in data that where, or is there any data which actually can predict the HbA1c from this point of range testing? This is again a second patient, the same kind of data you can see. Most of the time the fasting glucose is less than 105. The pre-meal sugar, most of the time it is less than 120. There are only 2 points which are above 120. This is again the post-meal blood glucose levels which are again less than 140. So this is again a very compliant patient who is regularly monitoring their blood sugar, and they are actually adding some value to their data. So this is again the dashboard of these some other systems where now we have all, as Bansi sir has seen, that this is from the Vario where you can see the data. This is the another point. So this is important to understand that there is a significant correlation between HbA1c and the PIR, which can be calculated by the integrated digital technology. In one of the study, I will not go into the details of this study, but this is important to highlight that in the study, what this study was found that there was a significant difference between type 1 diabetes and type 2 diabetes in all metrics except the percentage of the point above range. And this is the most important slide, which tells us that the point in range of 70% measured over 2 months correspond to HbA1c of 7.2%. So if a person was having in point of range for more than 70% of the times, that it was likely that the HbA1c of the patient would be somewhere around 7.2 with plus minus some variations. Again, the PIR of 70% measured over 2 weeks correspond to an HbA1c of 7.1%, and every shift in PIR by 10% corresponds to a change in HbA1c of around 0.4%. So this again, this kind of prediction can help us in estimating the HbA1c and overall control of the patient. So this is what we wanted to highlight in this talk. So thank you very much for the patience listening, and I was very brief in this because a lot of things have already been covered by Dr. Dandania and Dr. Maluk and Dr. Bansi sir. Thank you.
Fantastic. Thank you, sir. So now we have 2 speakers from the session. Any points of discussion that we can discuss, or any highlight you touch upon before we close the session?
One thing which I would like to stress upon is when you are writing a prescription, we should also prescribe for monitoring as well, which we are not doing. I think that is very, very important part of this particular meeting. For each and every patient, we should prescribe that this should be monitored like this. Only then we are going to have things getting into the head of the patient's mind. You understand? And you should tell these patients, come with a written record. Don't write it in their mind. I've been doing blood sugar regularly, but if you don't have a record of it, how does it help? It doesn't help. And when they are doing a blood sugar, tell them to do it in a structured way. That is also, this comes to be the third one. Otherwise, kya hota hai malum hai, most of the times the strip gets expired. So that is what is happening. And to all the healthcare professionals, I'm saying all the healthcare professionals looking after diabetic patients, use point of care. I'm telling you, it's a very, very useful tool for the patients and their outcome. At least they learn monitoring from your clinic. That is one thing that they can learn in a clinic. Use a authenticated glucometers. Don't use the unauthenticated glucometers in your clinic. They may not give you much earning. They will give you less of earning because the strips are expensive, but they'll give you a good data. And patient learns from it how to do it by seeing the process of doing it. And they find it very, very easy, painless, almost painless. Tell them to prick on the lateral aspect of the digits. That is almost painless. And they see the result in 5 seconds. That is how they learn it. So first glucometer encounter in a clinic. Then the second encounter is your HbA1c. The third encounter is your lipids. So everything becomes so simple for them. So all the doctors should at least try to install these devices in the clinic. Our own critics are our colleagues, let me tell you very, very honestly. Yes.
Some of the patients will technology. Some of them would like to use SMBG. Some would like to use CGM. Some you may have a POC device, but still somebody would say that I would like to go for a prick and send the sample to the lab. So there is a space for everything, and as a practicing professionals, we should have an open mind to all the technology, whatever is coming to us. What I believe.